Hi, this is Dr. Poole, and this Chalk Talk is about the, quote, other leukoencephalopathies. Now, there's a huge list of white matter diseases, and sorry for the deliberately vague title, but I've picked these particular entities out, number one, because they can overlap clinically with multiple sclerosis, but also, and probably more importantly to you, these particular entities I didn't just pick out of thin air, but I picked because they are specifically on the outline for the good old U.S. MLE Part 1 exam. So at least we'll have these covered. So the first other leukoencephalopathy is thiamine B1 or vitamin B1 deficiency. Vitamin deficiencies are a significant cause of neurologic disease in developing countries and in certain high-risk groups in developed countries, such as chronic alcoholics, patients with gastrointestinal diseases, and patients receiving long-term parenteral nutrition with inadequate vitamin supplementation. They can also result from lifestyle factors such as vegetarianism or from a wide variety of medical and psychiatric conditions. Thiamine deficiency causes Wernicke's encephalopathy and beriberi. Wernicke's encephalopathy usually complicates chronic alcoholism, but can also be associated with gastrointestinal disorders such as hyperemesis, gastrectomy, or gastric carcinoma, and rarely total parenteral nutrition with inadequate vitamin supplementation. Thiamine pyrophosphate is a cofactor in several enzymes, the pyruvate dehydrogenase complex, 2-oxyglutarate dehydrogenase, and transketolase. The encephalopathy probably is due to the energy deficiency that results from impaired enzyme activity, particularly with transketolase. And that's all I'm going to say about that. Okay, I'm going to talk about some of the clinical features. Wernicke's encephalopathy usually manifests acutely with gaze palsies and ataxia, which rapidly respond to thiamine administration. Apathy and clouding of consciousness, that is, acute confusion or delirium, may form part of the initial presentation, though these symptoms often develop later if the encephalopathy is left untreated for more than a few days. Wernicke's encephalopathy is sometimes associated with Korsakoff psychosis, which is characterized by retrograde and anterograde amnesia, that is, impaired recall of events before the onset of illness and of new information, as well as confabulation, which is just making stuff up. This does not respond to thiamine and is usually irreversible. The combination of Korsakoff psychosis with Wernicke encephalopathy is known as Wernicke-Korsakoff syndrome. I'm glad that's over with. Now I can get back to what I'm more comfortable with, the pathology. So lesions are usually discernible in the mammillary bodies, but may also involve other parts of the hypothalamus, the medial thalamic nuclei, the floor of the third ventricle, and periaqueductal region, the colliculi, the nuclei of the pontomedullary tegmentum, particularly the dorsal motor nuclei of the vagus, as well as other sites. Typically, the involved regions are slightly shrunken and show brown discoloration, and there may be petechial hemorrhages. So this, to start off with, is the normal shape and color of normal mammillary bodies. Now observe the shrunken brown mammillary bodies in this image, and in the next slide, the presence of petechial hemorrhages in cases of Wernicke's encephalopathy. See the brown petechial hemorrhages, especially noted in the left mammillary body. Other typical regions we see are in the periaqueductal region and in the colliculi and floor of the fourth ventricle, as you see in the right image. This is a myelin stain showing extensive loss of myelin in the mammillary body, as well as an increase in cellularity. Acute lesions are also edematous with relative preservation of neurons, variable necrosis of intervening tissue, and again loss of myelinated fibers, which you see here. This is a section of hypothalamic and periaqueductal lesions showing petechial hemorrhages in the periaqueductal gray matter. This is pointed out by the prominent capillaries which show hemorrhage around them. This is a higher magnification view, again showing the petechial hemorrhages, this time in the hypothalamus. And this is what eventually gives it the reddish-brown appearance when the hemoglobin is broken down into hemosiderin. The neuronal cell bodies that you see here are relatively preserved, although some of the neurons appear abnormally swollen. The increased prominence of capillaries is shown here to the right. There may be petechial hemorrhages and hemosiderin-laden macrophages, and this is an iron stain, which shows the iron pigment from the breakdown of hemoglobin staining this blue color. This also explains the brown color seen on macroscopic examination because hemosiderin has a rusty brown appearance. Chronic lesions, such as shown here, appear gliotic and slightly spongiotic or loose in appearance, with mild loss of neurons, depletion of myelinated fibers, and scattered hemosiderin-laden macrophages. And this is our friend the myelin stain showing the myelin depletion in the mammillary body. I'll sum up all the gross and microscopic features for the entities that I'm going to cover in this talk at the end. So let's move on to toxic encephalopathies. Again, there's a wide range of different chemicals and drugs that can cause toxic encephalopathies, but I'm going to focus on methanol poisoning since, again, that's a USMLE topic. Methanol, or methyl alcohol, is widely used as a solvent, but poisoning is usually a consequence of its ingestion as a cheap inebriant, or cheap buzz, or it's something that's added to as an adulterant of liquor. Classically, since a car radiator is a perfect and cheap way of distilling moonshine, methanol poisoning has occurred with moonshiners inadequately removing the antifreeze, which contains a large amount of methanol, from car radiators, and then start distilling their shine. The clinical manifestations of acute toxicity are delayed for several hours, since toxicity is believed to be due to the formaldehyde and formic acid that are produced when it's oxidized in the liver. Patients develop headache, abdominal pain, nausea and vomiting, and generalized weakness. Loss of vision is a common and usually permanent complication. Severe intoxication may cause delirium, convulsions, coma, cardiorespiratory failure, and ultimately death. Neuroimaging typically reveals characteristic changes of hypoxic damage involving the putamen, and in more severe cases the caudate nucleus, cerebral cortex, and subcortical white matter. Foci of hemorrhage are common, particularly in the putamen. In acute methanol intoxication, the brain is usually edematous and shows features of global hypoxic injury, which we've talked about before. There may be scattered petechial hemorrhages and larger symmetric foci of hemorrhagic infarction in the putamen. And this is the classic gross and microscopic findings of acute methanol toxicity. In severe cases, hemorrhagic necrosis of the putamen is accompanied by more widespread hypoxic damage to the cerebral cortex, as well as extensive white matter necrosis, which is how it may fall under the consideration with MS or other demyelinating diseases. This is a montage of different microscopic findings that you can see with extensive hemorrhagic necrosis in the putamen in the upper two panels, as well as necrosis of subcortical white matter and parts of the cerebral cortex in the lower panels respectively. Let's move on to metabolic disorders and adrenoleukodystrophy, which is one of the lysosomal or peroxisomal disorders. Now there's a large variety of inherited so-called errors of metabolism that can produce leukodystrophy. Again, I'm just picking on adrenoleukodystrophy because it's a USMLE topic, but just be aware there's a wide variety of these rare errors of metabolism. They all have some similar pathology and are lumped together and discussed as leukodystrophies. Adrenoleukodystrophy is due to a single peroxisomal enzyme defect of an ATP binding cassette transporter, which reduces the capacity to form the coenzyme A derivative of very long-chain fatty acids. The primary pathologic changes that one finds with this are in the adrenal gland, which I'm not going to discuss here, as well as in the brain. Adrenoleukodystrophy may present in infancy, childhood, or adulthood. In infancy, the clinical presentation is that of hypertonia, seizures, failure to thrive, deafness, and retinal degeneration. In childhood, the presentation is forms of developmental delays, hearing and vision problems, progressive pyramidal, extrapyramidal, and cerebellar disorders, and then dementia. In adulthood, the usual presentation is with clumsiness or spasticity. There's a schizophrenia-like syndrome that's described, as well as dementia. Macroscopically, the affected white matter, which is outlined in red here, is firm and gray, and usually more severely affects the posterior part of the brain, as here, rather than anteriorly, which we'll see in the next slide. In this anterior coronal section, there really isn't much grossly abnormal. This is a myelin-stained section through the frontal lobe, which shows extensive myelin loss in the centrum semiovale and corpus callosum, but with sparing of the U fibers. And this is a characteristic pattern of adrenoleukodystrophy. The next two slides show characteristic microscopic findings of adrenoleukodystrophy. First, there's prominent perivascular collections of lymphocytes, and then accumulation of numerous macrophages, here as shown as dark red blobs with the PAS stain. This is because these macrophages are ingesting abnormal lipid material because of the accumulation of abnormal fatty chains, and these can be identified with staining with the PAS stain. In lesions of active myelin breakdown, the sections show accumulation of these macrophages, which have a foamy type appearance because of the lipid accumulation. And then one of the pathognomonic findings, meaning you better be able to recognize this, are these striated lamellar material that accumulate in macrophages. So they have this sort of spiraling or layered appearance. The final white matter disorder is progressive multifocal leukoencephalopathy. In contrast to other viral diseases that we'll talk about in an upcoming case that may cause meningitis or encephalitis, this is more characterized by the breakdown of myelin material, which again is why it's kind of lumped into here, even though it's an infectious disease. PML is caused by the JC virus, one of the two ubiquitous polyoma viruses, the other being BK virus. Infections in humans are generally asymptomatic. Latent JC virus is demonstrated in the kidneys and B cells in the tonsils of most adults and in some in the brains. PML is thought to result from reactivation of latent JC virus within the CNS or peripheral tissues, usually as a result of impaired cell-mediated immunity, most frequently in HIV infection. Patients present with focal neurologic defects including dysarthria, limb weakness, visual disturbances, ataxia, personality changes, and occasionally seizures. PML usually progresses relentlessly over a few months, resulting in increasing neurologic impairment, dementia, and eventually death. This is a coronal cut surface of brain affected by PML, showing asymmetrically pitting by small foci of gray discoloration mixed with larger confluent areas of abnormal parenchyma, which may be centrally necrotic, as seen in the yellow circle. These lesions tend to be most numerous in the cerebral white matter, but also involve the cerebral cortex and deep gray matter. The cerebellum, brainstem, and spinal cord are less commonly involved. This is a higher magnification view showing confluent foci of gray discoloration in the cerebral cortex along here, as well as in the white matter. This is a section including basal ganglia and the hypothalamus, stained with a myelin stain showing multiple foci and confluent areas of demyelination. Some of these foci appear small and rounded, while there's a large irregular confluent area with central necrosis. This is a higher magnification of one of these areas, again with a myelin stain, showing irregular areas of loss of myelin indicated by the pale negatively staining areas. These lesions contain moderate numbers of foamy macrophages, but only scanty perivascular lymphocytes, which is something that distinguishes it both from MS and from adrenoleukodystrophy. Another characteristic histological finding are these bizarre astrocytes. A striking, again, characteristic feature, particularly in older lesions, is the presence of these very large astrocytes, sometimes which have bizarre pleomorphic hyperchromatic nuclei. So these are these large dark pink or purple blobs of nuclei. These cells actually resemble the malignant astrocytes that can be seen in a primary brain tumor called glioblastoma. Typical reactive astrocytes are also present in the background. This is an immunohistochemical stain for SV40 virus, which is another name for the JC virus, and identifies virus in the oligodendrocytes near the edge of a focus of demyelination. Again, note that there's very scanty lymphocytic cuffing of small blood vessels identified here. Okay, so let me sum up. What did I learn? Thiamine deficiency, Wernicke encephalopathy. The affected areas are the mammillary bodies, periaqueductal gray matter, the floor of the fourth ventricle, and thalamus. The affected areas are dusky and hemorrhagic in the acute phase, and atrophy can be seen in the mammillary bodies in chronic cases. Microscopically, there's gliosis with partial preservation of neurons as well as pericapillary hemorrhages. In adrenoleukodystrophy, grossly, we see confluent symmetric lesions, particularly in the parietal occipital lobes, or the posterior part of the brain, more than the anterior part. Grossly, there's brownish discoloration and depression of the cerebral white matter, corpus callosum, posterior limb of the internal capsule, and optic system fibers. Microscopically, we see numerous macrophages that are PAS positive for myelin material, as well as the pathognomonic striated lamellar material. Finally, there's reactive astrocytosis in the demyelinated white matter. The key finding in methanol poisoning is involvement of the putamen. In acute methanol intoxication, the brain is usually edematous and shows features of global hypoxic injury. There may be scattered petechial hemorrhages and larger symmetric foci of hemorrhagic infarction in the putamen. In severe cases, hemorrhagic necrosis of the putamen is accompanied by more widespread hypoxic damage to the cerebral cortex and extensive white matter necrosis. Microscopically, you see putamenal cavitation, macrophage accumulation, and gliosis. And finally, with progressive multifocal leukoencephalopathy, there are demyelinating lesions in the subcortical white matter. There's a predilection for the parietal-occipital regions. Microscopically, there's myelin loss with a macrophage-rich background, enlarged oligodendrocyte nuclei with a ground glass appearance, which stain positive for antibodies to JC virus. And finally, a key feature are the presence of bizarre astrocytes, which have hyperchromatic enlarged nuclei. So that ends my discussion of these other leukoencephalopathies, and that ends my presentations for this case. See you next time.